Welcome. Today I'm going to be talking about cortisol and aldosterone. I apologize if I'm a little raspy going through this one today. I've been trying to fight off a viral infection and not been very successful at it. But anyway, I'm Matthew Greer. This is presented for Bio 515 through Grand Canyon University. My instructor is Dr. John Talzone. Today's date is the 15th of December. Without further ado, let's jump straight into cortisol and aldosterone. We're going to be taking a look at these adrenal glands here, the little hat-shaped ones on top of the kidneys. So first off, the adrenal gland, this little piece here. You have two of them. You have one on top of each kidney. Ad means next, and renal means kidney. So adrenal, if you dissect that word together, means next to the kidney. There is an inner and outer portion of the adrenal. So here's where it is anatomically, and then here's a cross-section looking on the inside. You have the cortex, which is this outside layer, which makes and secretes steroid hormones, and then the medulla, which makes catecholamines on the inside there. The medulla is responsible for making substances like epinephrine and norepinephrine. It's not where we're going to focus our study today. We're going to be looking at mostly the cortex and mostly just two layers of the cortex. The cortex itself is further separated into three layers. And going from outside to inside, we have the zona glomerulosa, the zona vesiculata, and the zona reticularis. And each one of these zones secretes something different. The zona glomerularis, the top here, secretes mineralocorticoids, and this is where aldosterone is going to be secreted from. And then the zona vesiculata, here at the middle layer, secretes the glucocorticoids. And glucocorticoids is going to have sugar in them. This is going to be cortisol. And then the zona reticularis is where you're going to have your sex hormones, both for male and female. So estrogen, testosterone. These chromaffin cells down here, this is where epinephrine is made in the medulla. But we're looking at the cortex today, and specifically for aldosterone and cortisol, we're looking at the zona glomerulosa and the zona vesiculata. So let's start with aldosterone. Both of these are cholesterol derivatives. So I have a molecule of cholesterol over here, and then very similar to it, a little bit different, is this molecule of aldosterone. The zona glomerulosa secretes aldosterone when stimulated by adrenocorticotropic hormone, this ACTH. However, how big this zone is at any time is controlled by renin. This is a part of the renin-angiotensin-aldosterone system. And because of that, aldosterone is very important for the body's ability to regulate blood pressure. So we get aldosterone secretion and production when we get low blood pressure, and this causes the reabsorption of salt as sodium ions. And as that salt gets reabsorbed through that nice process of osmosis and osmotic pressure, water always chases salt. Remember that. Water always goes to salt. So if there's more salt on the outside of the cell, water is going to go out of the cell. If there's more salt on the inside of the cell, water is going to go in. So that's aldosterone. Cortisol, on the other hand, released by the zona vesiculata when it's stimulated by ACTH. And cortisol has four main roles that we're going to talk about. It stimulates liver gluconeogenesis, so the creation of glucose. It inhibits glucose uptake by many tissues, but not the brain. Remember that the brain can't store any glucose up there, any glycogen or anything like that. So we need blood sugar at all time in our body to be able to, our brain to use that. We have that very specific blood-brain barrier. Without blood sugar, we can't get that sugar inside of the brain. It'll stimulate protein degradation in muscle cells. These amino acids will get broken down and turned into glucose. And it facilitates lipolysis, which is the breakdown of fats, and releases fatty acids into the blood. Yeah, it's also called the stress hormone. It is a negative feedback, so ACTH is from the anterior pituitary, so ACTH, it gets stimulated by the corticotropin releasing hormone, CRT. Go on down here, which will come down and stimulate cortisol production and secretion from the adrenal glands. It's in a negative feedback loop, so this will go back up here and cancel these ones out, both of them, to stop its own production. Now, the rest of this presentation, we're going to talk about what happens when we have hyper or hyposecretion of either aldosterone or cortisol. So in aldosterone hypersecretion, so hyper means over secretion, there's going to be more aldosterone than normal. We have two types. We have primary hypoaldosteronism, which is Collins syndrome. And this is what I have a picture of over here, when we have this adrenal mass, and specifically an adrenal mass that is producing aldosterone. It's not just a mass, it has to be an aldosterone producing mass. And so because of this extra salt that's being reabsorbed, we're going to have high blood pressure, we're going to have a high osmotic pressure inside of the body. And this is very hard, very stressful for the kidneys that have to filter out that. It is very stressful for the heart to pump all that extra stuff. It can have extra cases of strokes, increases the risk of that. All that stuff we'd expect to see with hypertension. And then secondary hypoaldosteronism, this is caused by chronic reduction in arterial flow to the kidneys. So we're getting reduced blood pressure to the kidneys, we're getting that aldosterone secretion, and once again we're getting that hypertension due to these increased sodium levels. In Cushing's syndrome, this is not aldosterone at play, this is an excess amount of cortisol. So this happens as the adrenal cortex is overstimulated by ACTH or CRH, those corticotropic releasing hormones release, and this leads to an increase in cortisol secretion. We refer to it sometimes as adrenal diabetes as well, because we have some of the symptoms you'd see in diabetes, like high blood glucose and glucose in the urine. What's happening here is there's an excessive amount of amino acids being converted to glucose. This glucose is in the bloodstream now. It's too much for the kidneys to filter out, so it ends up in the urine. So we end up with high blood glucose and low protein storage as these excessive amino acids are being broke down. Some of the symptoms, this nice diagram here, you have this fat pad or this buffalo hump where glucose is being packed kind of weird. You have stretch marks, thinner arms and legs, this moon face, this very round, red cheeks, moon face is a very common symptom in Cushing's syndrome. Now, on the other side, we've talked about two examples of hypersecretion where we've had too much. Let's talk about hyposecretion. So this is when we have, when we have a lower than normal amount. So both layers, or all three layers, of the adrenal cortex are under secreting. This is usually in Addison's disease due to an autoimmune destruction of the cortex, of that outside layer of the adrenal glands. So both aldosterone and cortisol will be low. So because of this, we have fatigue. Patients are very tired. We have hypotension, which is the opposite of hypertension. So hypertension was high blood pressure. Hypotension is going to be low blood pressure. And we have changes in skin color. And then I have this diagram over here. Some symptoms are lack of appetite, weight loss, nausea, vomiting, diarrhea. These two kind of go hand in hand. If you're getting nauseous, you're not really hungry. Joint pain, muscle pain, this melanistic darkening of the skin, and then fatigue, irritability, and depression. We have a lot of the body systems working together, the hypothalamus, the pituitary, the adrenal glands, the kidneys. All of these are this interplay and these negative feedback loops here. So when one thing goes wrong, you have not just one system now that is being affected, you have an entire body. All 11 body systems are now at risk here instead of just one. I hope You learned some things about aldosterone and cortisol through this. Learned a little bit more about adrenal gland, its structure, secretion, and what goes wrong. These are the sources that I referenced throughout this presentation. The textbook has lots of good things in it. This Parmer has really good stuff on Conn syndrome. And then Addison's disease, the new has a lot of good stuff there on Addison's disease and different treatments and symptoms. Goes into a much deeper depth than I did. I hope you enjoyed this presentation. Thank you for watching. Goodbye.